Pleural abnormalities, respiratory alterations in pulmonary function, part 2. Pleural abnormalities, pneumothorax. Keep in mind that the pleural sac is a thin double-layered membrane that surrounds the lungs, and any air or gas in that pleural space will cause a collapsed lung. So they're different, and pneumo means air and thorax means chest, so there's air in the chest cavity. If it's open or communicating, it means that the air pressure equals the atmospheric pressure. Tension pneumo, it means the site of rupture acts as a one-way valve, allowing air in but not out. So it puts pressure on the internal organs, causing a mediastinal shift, or causing the lungs and the heart to shift to the opposite side. Rather dangerous. Spontaneous is usually due to a rupture of a bleb or a bullae. Now, a bleb or a bullae are like a little outpouching on the lung tissue where it's a little bit thinner. This usually occurs in young men between 20 and 40 who are otherwise healthy. They may need to have a chest tube put in, they may not. But a bulla is a large vesicle, and a bleb is usually just like a blister on the viscera of pleura. So a bleb is not a big thing if it ruptures, but a bulla is. Pneumothorax can also be secondary to trauma, such as if somebody takes a knife and sticks it in a chest, or a bullet or something like that, or as I mentioned, the bleb rupture. Symptoms are sudden onset of pain, dyspnea, and tachypnea. And this is showing a pneumothorax from the memory book. It goes into diagnosis and or treatment also. Pleural effusion is the presence of fluid in the pleural space. And there's a table on page 722 that talks about the different types of fluid. But pleural effusion can cause a mediastinal shift and atelectasis, but it does not cause the lung to collapse. Empyema is an infected pleural effusion. This is where you have pus in the pleural space due to an obstruction of the pulmonary lymphatics or in pneumonia with contaminated lymph fluid going into the pleural space. Symptoms are cyanosis, fever, tachycardia, cough, pleural pain, and diminished breath sounds. Pleurisy is inflammation of the pleura with chills, fever, pain on inspiration, and it can occur with or without a rub. Now, an abscess is a circumscribed area of suppuration, or pus, and destruction of lung tissue due to consolidation. Inflammation causes the alveoli to fill with fluid, pus, and microbes. Symptoms are fever, cough, chills, sputum production, hemoptysis, which is a bloody cough, and pleural pain. The usual cause of the is Staphylococcus or Klebsiella. If it causes cavitation, that means you have the abscess goes to the bronchus and has formed a cavity. Pulmonary fibrosis is when you have an excessive amount of fibrous or connective tissue in the lung that causes a decreased compliance of the lung. The lung doesn't stretch as well. This can be idiopathic due to inhalation of toxins or due to active disease. Symptoms are the lung is stiff and difficult to ventilate. You'll have a decreased diffusion capacity that causes hypoxemia. It can develop from allergic inflammation of the alveoli, usually due to an inhaled allergen that causes the alveoli to become inflamed. Changes in the chest wall increase the work of breathing. Symptoms are dyspnea, dyspnea on exertion, decreased pulmonary function, increased risk for pneumonia, and respiratory failure. Causes might be kyphoscoliosis, which is a lateral bending and rotation of the spinal column. Do that and take a deep breath. Not so easy. Could be due to obesity or ankylosing spondylitis, which is a rheumatoid arthritis of the spine. Pectus excavatum It's when you have a funnel chest with depression of the sternum. I don't know if any of you ever used to watch Jay Leno at night, but they showed a college student who used to eat his cereal out of his chest because he had pectus caveatum, and it was like a regular bowl that he could use on his chest, on his rather than using a dish. Neuromuscular disease could cause it, such as polio, muscular dystrophy, myasthenia gravis, or Guillain-Barré syndrome, and we'll be talking about some of those when we do neurologic. Could be due to a flail chest. Now, a flail chest is a fracture of the ribs, all the ribs, causing paradoxical movement of the chest wall when you breathe. So instead of breathing out, when you breathe out, your chest goes out rather than in. When you breathe in, your chest goes in rather than out. The patient will complain of pain, dyspnea, unequal chest expansion, hypoventilation, and hypoxemia. Inhalation disorders occur from exposure to toxic gases such as smoke, ammonia, hydrochloric acid, sulfur dioxide, chlorine, nitrogen dioxide. That will cause damage to the alveoli and capillaries, and it will cause pulmonary edema. Oxygen toxicity occurs with oxygen concentrations of 50 to 75% for 24 to 48 hours. This will result in a severe inflammatory response, and the symptoms initially are very vague, like a stuffy nose. So you need to be careful with that. Pneumoconiosis is due to the inhalation of dust particles with progressive fibrosis of the lungs. Dust particles like silica, asbestos, coal, talc, fiberglass, clays, or cement. It causes permanent, irreversible damage. You'll end up with a cough, dyspnea, chronic sputum production, decreased lung volume, and hypoxemia. Acute lung injury, also called adult respiratory distress syndrome, or ARDS, is injury to the lung resulting in acute lung inflammation and diffuse alveolar capillary shunting. It causes pulmonary edema, hemorrhage, shunting of blood, pulmonary hypertension, vasoconstriction of the pulmonary vascular beds. 65% of patients who have acute lung injury will die because of multiple organ dysfunction syndrome, resulting from generalized endothelial damage and capillary permeability throughout the body, increased capillary permeability throughout the body. It is fulminant in nature. It causes fibrosis of the alveoli, respiratory bronchioles, and interstitium, causing a severe right to left shunt. Chemical mediators will cause systemic inflammatory response syndrome, which will lead to multiple organ dysfunction syndrome. Symptoms are rapid, shallow respirations, respiratory acidosis, dyspnea, decreased lung compliance, inability to make the lungs expand, profound hypoxemia that is unresponsive to oxygen supplementation. So it doesn't make any difference how much oxygen you give them. It doesn't do any good. Risk factors are sepsis, multiple trauma, pneumonia, burns, aspiration, coronary artery bypass, graft surgery, pancreatitis, overdose, or disseminated intravascular coagulopathy. The patient will initially hyperventilate. That will lead to respiratory alkalosis. That leads to dyspnea, decreased oxygen intake, increased metabolic acidosis, hypoventilation, respiratory acidosis, hypoxia, hypotension, decreased cardiac output, and death. ARDS in children, or acute lung injury in children, have a 50% mortality. And children, the symptoms are a little different. It's very acute onset. They'll have progressive respiratory distress, severe hypoxia, that again is unresponsive to supplemental oxygen. Hyperventilation eventually occurs due to fatigue that leads to the hypercarbia. And here's a flow sheet showing acute lung injury. As you can see, it starts off with clinical lung injury, causes endothelial damage and epithelial damage in the lungs, and the whole thing goes down to acute respiratory failure. This is a diagram from the memory book, again, that's showing acute respiratory distress, now called acute lung injury. Just a way to try and help you remember. It's white lung because you look at the x-ray and it's filled with fluid. Acute lung injury, adult respiratory distress, acute respiratory distress syndrome used to be called a non-cardiogenic pulmonary edema, because that's what it is. It's not, they get pulmonary edema that's not due to any problem with the heart, it's due to the lungs. Obstructive pulmonary disease is when you have, it could be due to asthma, emphysema, or bronchitis. Chronic obstructive pulmonary disease is emphysema and bronchitis, usually. Asthma is when you have a spasm of your bronchial smooth muscle. The muscles of the smooth muscle, due to the acute inflammatory response that causes production of a thick, tenacious, or really sticky sputum that causes airway obstruction. It's really hard to cough it out. Symptoms, if they're in remission, there's none. During the attack, they're dyspneic, have increased respiratory effort, use of their accessory muscles, wheezing, bronchospasm, mucus plugging, and diminished breath sounds. They'll have tachycardia, tachypnea, and coughing. There's a flow sheet on page 729 that shows this. If they develop status asthmaticus, this is unrelieved bronchospasm, which can lead to death. Now, there was a movie a few years ago called The Hand That Rocks the Cradle. This is a good example of status asthmaticus because it shows the increased work of breathing, the hypoxemia, and the respiratory acidosis. It initially will cause respiratory alkalosis due to tachypnea, then acidosis as the carbon dioxide is retained. Risk factors for asthma are it's a familial disorder, could be due to allergens, urban residence, air pollution, cigarette smoking, or respiratory viral infections. But this movie, The Hand That Rocks the Cradle, is a good mystery also. So I highly do recommend it, but it does show somebody who has adult asthma and then goes into status asthmaticus and how it's treated. It's very well done, actually, for Hollywood. Asthma in children is the most prevalent chronic disease of childhood. Symptoms are tachypnea, cough, wheeze, shortness of breath, tachycardia, possible upper respiratory infection due to the RSV virus, nasal flare, sternal retractions, dyspnea, a barrel chest due to hyperinflation, anxiety, diaphoretic, and ventilation perfusion mismatch. And the memory book is showing reactive airway disease due to somebody who has asthma. So they have trouble getting oxygen in. This is showing the pathophysiology of COPD. Could be tobacco smoke, air pollution, an alpha-1 antitrypsin deficiency, where you have breakdown of the elastin in the connective tissue of the lungs. This is looking at emphysema and chronic bronchitis. And you end up with an abnormal ventilation perfusion ratio, hypoxemia, hypoventilation, and left heart failure if it's untreated. These are some of the changes that occur in COPD. If you have emphysema, the walls of the individual air sacs appear torn. Repair is not possible. The bronchioles will collapse. You'll have trapping of air, and exhalation is difficult. The lung tissue becomes inelastic. The lungs are enlarged, resulting in a barrel chest appearance. They will have an increase in compliance. In other words, they get lots of air in, but it's trapped. It can't get back out. Bronchial asthma, on the other hand, you'll have swollen mucous membranes of the bronchial tubes and the surrounding tissue. The muscles of the bronchial tubes become spastic, causing narrowing. You'll end up with thick mucus that fills your bronchial tubes and the alveoli, and breathing becomes labored, expiration difficult. These patients have decreased compliance. They can't get the air in. Okay, so they end up being the blue bloaters, where the emphysema is the pink puffers. Because CO2, as you retain it, causes vasodilatation and makes you look more ruddy in color. And then chronic bronchitis. Again, the bronchial tubes are narrowed as a result of the thickened mucous membrane. Surrounding tissues inflamed. You get mucus and pus that impede the action of the respiratory cilia, and you have a cough, a chronic cough. Chronic obstructive pulmonary disease. You're going to have bronchitis. Bronchitis is inflammation of the bronchi. Symptoms are acute. We'll have fever, cough, chills, malaise, and it can progress to pneumonia. It's usually due to a virus. If it's bacterial, that usually occurs after the virus or in somebody who has COPD. Chronic bronchitis is the hypersecretion of mucus and chronic productive cough for at least 3 months that occurs at least in 2 consecutive years. The symptoms are productive cough, wheezing, prolonged expiration, cyanosis, because of the narrowing of the bronchi, polycythemia, increased red blood cell count because you're trying to get more oxygen around, cor pulmonale, which is right heart failure due to lung problems, and thick tenacious mucus. They end up being a blue bloater. In other words, they're hypoxic because of the secretions. They're at risk for recurrent infections, hypoventilation, right ventricular failure. There will be no infiltrate on their chest x-ray. Dyspnea will occur late in the process. There's a flow sheet on page 730. It's usually due to smoking and air pollution. This was a bronchitis symptom. Kind of, you get all the mucus that comes in to live into your house. It was on television, and I just kind of thought it looked cute. And this is a haha. My report today is on dinosaurs. The largest dinosaur that ever lived was the bronchitis. It soon became extinct. It coughed a lot. Haha. Chronic bronchitis, again, the blue bloater. You're going to have the dusky color to cyanotic. They're going to be hypoxic, hypercapnic, which is a high CO2. They're going to need supplemental O2. They'll have clubbing. This again is from the memory book. And this is from the memory book. It's showing somebody who has COPD, which is a chronic airflow limitation. Looking at both bronchitis and chronic bronchitis and emphysema, what they look like. Cor pulmonale is late in the disease process. Emphysema is the abnormal permanent enlargement of the acini with destruction of alveolar walls and obstruction with loss of the elastic recoil. So they can, and the lungs can expand but not retract. So you'll have somebody who has increased compliance. The acini are your gas exchange airways. It's due to an inherited deficiency of your alpha-1 antitrypsin or chronic bronchitis or smoking. There are 2 types, centriacinar and panacinar. The centriacinar is inflammation of your bronchioles. The panacinar occurs more in the elderly and for those who have an alpha-1 antitrypsin deficiency. And if you have an alpha-1 antitrypsin deficiency, you can get COPD very young. You're an adult, but still very young. You'll have symptoms are dyspnea, barrel chest, prolonged expiration, polycythemia, and cor pulmonale. These patients end up as pink puffers because CO2 is a potent vasodilator. They have no increase in mucus production as they do with bronchitis, and the productive cough will occur very late in the disease process. They have chronic hypoventilation. COPD is considered chronic bronchitis and emphysema. And these are the different types of chronic bronchitis. The top one is normal and what it should look like. The one in the middle is your centriacinar emphysema, and the one at the bottom is panacinar emphysema. Just so that you can see what the alveoli look like and the cells, the bronchioles look like. Pink puffers, emphysema, as you can see, it's usually due to smoking. They tend to speak in short, jerky sentences because they don't have a lot of air, and it's hard for them to do. Again, from the memory book. This is the benefits of chocolate, and most women will appreciate this. Chocolate is rich in antioxidants, which help protect cells and help detoxify the bad LDL cholesterol. That's true. Chocolate antioxidants act like aspirin to reduce the blood platelet stickiness that can trigger strokes. That's true. Chocolate may help prevent heart disease and high blood pressure by increasing nitric oxide, which improves vascular function because it's a vasodilator. That's true. And then they got into spinach is an excellent source of folate, and she says no more boring food facts. And she kept going. But chocolate really does contain theobromine, which relaxes smooth muscle in the bronchial tree and elsewhere in the body. So chocolate's a good thing to give to your chronic obstructive lung patient. It should be the dark chocolate because that's better. And again, they don't need to eat the whole box at one time. Respiratory infections. Pneumonia is an acute infection of the lungs due to bacteria, virus, or fungi. Gram-positive organisms cause about a 50% mortality rate. It occurs because we inhale or aspirate bacteria, which initiates the inflammatory response and the release of endotoxins. If it's due to viral infections, it's usually mild, but it can set the stage for a bacterial infection. And if it's viral, the sputum culture will be nonspecific, but your chest x-ray will show an infiltrate. Fungal infections occur in your immunocompromised patients. Your symptoms are fever, chills, cough, pleural pain, generalized weakness, hemoptysis, and an elevated white blood cell count. Now, community-acquired pneumonia usually is due to strep pneumonia or your mycoplasma pneumonia, particularly if you're young, or your H. influenza can also cause pneumonia. And this is your pneumonia flow sheet. You're going to have aspiration of your strep pneumonia that releases your bacterial endotoxins, causes the inflammatory response, causes red hepatization, which is where you get blood, and then gray hepatization, which is deposits of fibrin and pleural spaces, phagocytosis in the alveoli, and has to do with your neutrophils and your macrophages, your white blood cell counts. And then you get, hopefully, resolution of the infection where everybody gets better. And this is showing pneumonia from the memory book, where you have obstruction of the bronchioles, decrease in gas exchange, increase in symptoms, and it shows you the cough and the usual cause. If you're a child and get pneumonia, it's usually it's usually viral due to the respiratory syncytial virus, RSV. Tends to occur more in the winter and in the spring. Bacterial pneumonia causes a vascular engorgement, edema, and a fibrinopurulent exudate. So it's made up of fibrin and pus. A decrease in your gas exchange that leads to respiratory failure. The symptoms tend to have a gradual onset. They'll have a low-grade fever and a cough. Community-acquired pneumonia is usually due to pneumococcal pneumonia. Atypical pneumonia occurs in school age and young adults with symptoms similar to bronchopneumonia or bronchitis. There's a table on page 755 that talks about the different types, their symptoms, the onset, and the risk factors. You need to look at that. And this finishes part 2.